Okay, hi guys, thanks for joining. We're going to do some DDU practice for the next 6 months or so leading up to the exam, and we'll follow the DDU syllabus. I'll just show you this DDU syllabus so we're all on the same page. Um, so if you guys can see this, this is the DDU syllabus that we've got here. It's anyone can download it. And we'll sort of try and follow. If I go down to wherever it is, go past all the physics. The syllabus is a bit patchy, but it starts down here on page 17, where it just goes through obvious causes of shock, basically, then hemodynamic assessment, and then they've just got this like other, which includes like every valvular disease, shunts, thoracic pathology, intracardiac masses, and then general ultrasound. So we'll try and go through this in a bit of order each week. And what I was hoping that we could do is I'll send out 2 written questions to everyone a week in advance and try and do those to time if you can. You get 15 minutes to write the questions, 10 questions, 2.5 hours. I think they give you 10 minutes reading time at the beginning. That will be done. You'll be typing it. It's done on your computer at home, and they've got a special software that ensures that you can't cheat. I'm not entirely sure how that works, but apparently it does work very well. I think it sort of monitors, you have to have your camera on and it monitors your eye movements or something. But anyway, you'll be typing this thing. So as you're practicing these, practice it with typing. And yeah, so we'll do it. It's got 10 questions. Um, and it's marked out of, I think surprisingly, it's marked out of 15 per question. And you have to get over, I think it's 55 or 60% to pass the exam overall, and it's a cumulative score for the written. And then for the vivas, it's a 40-minute exam. It's you sitting down in control of the computer. So you won't have that with this, so it's a bit artificial, of course. But in the exam, yeah, it's about 7 or 8 questions, and it's 40 minutes, and you have to answer every question. So what we'll do each week is we'll go probably through a couple of written questions quite quickly, and then we'll go through a couple of Viva questions, and we'll see how far we get in about 45 minutes or so. So does that sound good? You got one sitting a year, um, and we see how we go from there. How does that sound? Cool. Okay. So I don't know if you guys had a chance to have a look at it because it was a little bit higgledy-piggledy this week for our first week, and so sorry if I didn't send out the questions in time. But these are the questions, and maybe we'll just talk through them a little bit. So can you see that okay? Cool.
Yeah, I can see it.
So these would be the kind of way that they're going to write the questions these days. So it's either just going to be a straight out question, such as what are the causes of aortic stenosis that you can find on an echo. That could be mark A for 20% of the questions. Part B will be what are the markers of severe aortic stenosis, and then part C would be what are the challenges in the critically ill or something like that. So that we're trying to be more descriptive about how the marks are spread out, try and be more descriptive about what is expected of you and less nebulous. So there'll be less of these questions like, tell me about diastolic function assessment in the critically ill. Trying to sort of go away from those and more to more up-to-date examining, which is just focusing on questions that are a little bit like this. As we go through these questions, can I just encourage you? We'll obviously try and answer these ones in the manner that it's that I've got sort of got in my head to how I'd mark these, but also try and think of how you change these round. Because I sort of go with the idea that I don't think there are that many ways that they can ask these questions. I don't think there are that many ways that they can ask in a written question about what you know about tamponade. It's either going to be about diagnosis, pathophysiology, or what are the tricky bits in a critically ill patient. And as far as I can tell, in the critically ill patients, it's integrating it with clinical findings. It's when you've got multiple causes of shortness of breath, how do you deal with that? And mechanical ventilation. And then we'll also think about other causes of pericardial disease, and that's mainly constriction or effusive-constrictive pericarditis. So I kind of tried to write a couple of questions about that this time, and why don't we just have a crack at going through them? Sound good?
Okay.
Cool. You guys are lining up for next year, aren't you? So we don't have anyone who's actually sitting. So we will be very gentle and we will go slow because these may be the first time you're writing these. But as I hope you're going to see, I don't think it's rocket science. It's all highly clinically relevant. And why don't we start at question one? Should we just alternate it round? So, Sarah, should we start with you for the first one? So,
Hmm.
so a 55-year-old woman is admitted to your ICU on high flow nasal prongs at 40/40. She's short of breath and in shock. Noradrenaline at 10 mils per hour single strength and a lactate of 4. She's a background of chronic renal failure. A JMO did a point of care ultrasound and found a 1 centimeter pericardial effusion and is worried about tamponade. So, real life clinical story. And then, what are the echo features of tamponade you would look for in this patient? So,
So I'd be looking for features on 2D echo, MO measurements, as well as Doppler parameters to assess for evidence of um, both pericardial effusion and tamponade. So on 2D, looking for evidence of pericardial effusion or space occupying lesion within the pericardial space. On 2D imaging in, I guess, the parasternal short axis, as well as in my subcostal and apical views, looking for evidence of interventricular interdependence, so RV encroachment on the LV with inspiration, as well as chamber collapse. So specifically looking for RV and RA diastolic collapse on echo. Um, Outside of the heart, I'd be looking for IVC plethora, as well as hepatic vein plethora if the IVC was difficult to image. On M mode, on in your parasternal long axis view, I'd be assessing again for that exaggerated inspiratory increase in RV cavity size, which is occurring in concert with LV decrease in cavity size, again implying that interventricular dependence. Um, and then on Doppler, I'd be looking at changes in E-wave inflow velocities across the mitral and tricuspid valve. So I would anticipate significant up to I think in the literature it says up to a 60% um, increase in E-wave velocity seen maximally after the first seen, increasing, augmenting on inspiration and decreasing on expiration, and the inverse occurring for the mitral valve. And then in the hepatic vein, blunting or reversal flow during diastole.
any phase of the respiratory cycle for that one?
During during inspiration.
Expiration.
Expiration, sorry, expiration.
Not bad. I love the way you split that up. So that's awesome. So again, you got 40% of marks. So that's going to be approximately, say, 6 minutes. I think you could have probably written all that down. Lovely ways. Absolutely. I think, Andrew, would you have said it done the same way, like M mode 2D?
That's how I
Um,
prepared. Yeah, I prepared something like that. Yeah.
Beautiful. Few cheeky marks to just stick in there as well. I'll just talk about the size of the effusion, and
Okay.
it'd be nice to be able to put into there about the size not being uh, the idea of whether it's tamponade or not. So, but
Yes.
you've mentioned it, and it's obviously about the rate of the expansion of the pericardial effusion.
Would you tie
Um,
it into even though it doesn't implicitly ask you to tie it into the clinical scenario, would you say something along the lines of like patients that, might be hypovolemic, such as this patient who may have experienced like diuresis or may have been dialyzed,
Great
may
question.
experience tamponade more readily in the presence of a small effusion if they have like a low volume state?
Yeah, it's really nice. And maybe that's what I should have put into the intro, when we were talking about what are the confounders in the critically ill, that could have been another way to write this question, right? So confounders in the critically ill would be the hypovolemia, where you can get that pseudo tamponade. That's what's so important about their IVC, plethoric IVC. And what was the other thing you said? So you talked about hypovolemia.
Uh,
I and
like sort of low volumes, yeah,
Yeah, low
hypovolemia, low
volume, and also
volume.
why the RV wouldn't collapse. What's the reason why an RV wouldn't collapse?
If you have pre-existing high right-sided
Yeah,
pressure, so
nice.
patients with
Yeah,
pulmonary
pulmonary
hypertension,
hypertension, and they got thick
lung
walls.
disease, yeah.
Yeah, beautiful. And yeah, very nice. You talked about the M mode and the parasternal long axis. I just think it's probably even better in the parasternal short axis, I find.
Okay.
So just and it's not too bad if you're looking at it in the subcostal as well. Anywhere where you've got that line going through either the right ventricle or the right atrium. So all of
Hmm.
those, and you were wedded to uh, particular windows when you were talking about looking for intradependence. I think you said
Oh,
the
okay. And
subcostal
don't
apical
get too
nerve.
fixated on it. Yeah.
Again, I just find a short axis is normally you didn't
Yeah. Okay.
mention. I thought the short axis is what I find is most clinically relevant. I don't think it's
Okay.
like a pass or fail, to be honest. I think
Yeah.
you put
Yeah.
everything in there. You talked about RV and RA diastolic collapse. I think if you're going to say that, you've got to say it's ventricular diastole or atrial diastole because it's normally it
Oh,
can
okay.
be,
Yeah. Sure. Sure.
with the RA, they particularly talk
Yeah.
about systolic or early diastolic collapse, but that's obviously ventricular diastole. It's just
Hmm.
whenever the pressure is lowest in the chamber.
Yeah.
Um, so
Yeah.
just being clear on that.
And even though you're talking about echo features in like the ASE document on this, they talk about how it correlates with your ECG, like the phase of the ECG. So it says, for example, like RV collapse is seen at the, near the T wave versus RA collapse seen at the peak of, your R wave. Would you like reference that, even though this is implicitly a question about echo features, or not bother?
I mean, I put it down as ventricular systole is what I normally like it. So I said like the RA would collapse during, ventricular systole,
Yeah. Okay.
and the RV will collapse during ventricular diastole or something like that.
Yeah.
In
Okay.
brackets, just when the chamber pressure is at its lowest. So I don't think there's any
Yeah.
hard and fast rules, to be honest, as long as you sound like you know what you're talking about.
Okay.
Um,
Great. Can I ask one other question about answering this sort of thing? When you have a question that is so, I mean, there isn't sort of like a keyword. It's not like this says like an outline question or an analyze or whatever. This is just a what is question.
It
Would
would
you
probably be
then,
written a little bit better, to be honest. That would have been, as I
okay,
said, I probably read this a little bit quickly. It would be something like list the echo features or
okay, yeah,
outline.
okay.
So if it's list, it's
Because I feel
obviously
like when
bullet
it says
point
things
single.
like, exactly, when it's like a describe or, there's a high level thinking thing, would you endorse putting a very short definition of what
Mm.
tamponade is before you start listing it so that you kind of frame your answer? Because for a
Yeah,
list question, I wouldn't, but I
I mean,
wasn't sure.
I think we've got 8 examiners now. They are all clinicians and
Mm,
they are all, dedicated echo people.
mm,
This is not quite as robust, and maybe I hope no one might raise me saying this when it's recorded, but it's not quite as robust as say like the SICM or the FANSCA exams, I imagine.
yeah,
Um, I think whatever you can do to nod to the examiner that you're a clinician who's using this and this is a game, but it's obviously what we're trying to get at. If you can do a
yeah,
quick nod to that, it's important. I think if you, I put the question as, echo features of tamponade, which means you've got to write down about echo. I'd still write as my first line, tamponade is a clinical diagnosis based on shortness of breath. That's why I wrote it in the question. I'd take a little nod to the
mm,
examiner saying, first of all, this patient is short of breath in shock. I'm probably going to need a really good reason not to drain an effusion if I think there's tamponade. The echo features is what's going to back it up for that for me. If I've got any
mm,
sign of chamber collapse during their low pressures, RV during early diastole, RA during ventricular systole. If I've got any variation, particularly if it's over 25 on the mitral valve, 40% on the tricuspid valve, if I'm seeing, I'll use 2D and M mode to look for those. If I'm seeing any ventricular interdependence, if I've got plethoric IVCs along with that, I will look for expiratory flow reversal in the hepatic veins. I would be very tempted to go and drain this. It's sometimes the diagnosis is difficult. Yeah.
hmm. Yeah. Okay. Awesome. Thank you.
Andrew, what about number two? So, what features are different if this patient is intubated and under full mandatory mechanical ventilation?
So you obviously going to change from negative pressure ventilation to positive pressure ventilation when you're under full mandatory ventilation mode. And this has an effect upon the interaction between the pressures of the ventricles and the atria. I think most critically, the largest change will be you'll get a change and a loss of the mitral and tricuspid variation, mitral tricuspid valve inflow variation. So the variations that you might see during negative pressure in ventilation will be either lost or greatly diminished.
Nice.
The second point would be
Okay.
that you would probably see a worsening of all features of tamponade, because you don't have that um, thoracic pump working anymore. So you'd expect to see a worsening of your RA collapse. You expect to see a worsening of your chamber collapse and probably a worsening in the shock of the patient. And then finally, I think you would lose intraventricular dependence to some degree. So you might lose your bounce.
Yeah, not bad, not bad. I think what the literature says in various case studies is, because nothing that you said is wrong, but you were talking about change and loss on at the beginning about the Doppler features, but then maybe exaggerated in other features. And remember that they're both inexorably linked, right? You know, the
Yep.
reason why we're getting some of these features of the collapse and particularly and then ventricular independence is because of the pressure that's built up around the heart and the tamponade and then transmitted pressures when you're breathing going into the cardiac chambers. So I think the literature kind of says basically is that it's a bit of a dog's breakfast, and you can get exaggerated responses or diminished and lost responses from mechanical ventilation.
Okay.
The IVC collapse is less reliable because obviously you've got increased intrathoracic pressures. So that's, that idea of trying to find that pseudo tamponade or that hypovolemic tamponade is harder. And then they talk about the tamponade physiology being less preload dependent because of the increased pressure and reducing the preload coming in. So I think if you just talk about changes in preload dependency, and then the changes that you talked about, just like you said, are either diminished, can be masked, particularly the Doppler features, and other features can be exaggerated. So I think you got a beautiful answer. I think you'd have got the good marks for that. And just remember, it's 20% of the marks, which means that you've got about, let's say, 3 minutes.
Yep.
Nice. So back to you, Sarah. So outline the procedure for echo-guided pericardiocentesis. You ever done this?
I'm not going to be your person to answer this.
Have you seen it
I
done?
literally have answered all these questions except this one, just blank. Because I'm aware that you can do it from different approaches, but in a real world scenario, how I would actually do this, I will do it the way that you tell me that you would do it because I have never done this.
Andrew, have you ever done this or seen it?
Give it a crack. I've seen it done blind. I haven't seen it done with an echo with an
So,
ultrasound. I have seen your images of
Concerning.
doing it.
maybe we'll try and record one. It's always a bit
Uh, I've
brain-sucking
seen a
to
recording
do.
of your one, I believe, a while ago.
I don't think I've ever
One you
recorded
did
this
need,
though.
or I may have just seen some images.
Well, let me talk you through this. So, what would I say? So maybe I'll split this up. If I was going to write this and I had, 6 minutes to write this, I'll try and separate it out into, before and after, or before the procedure and during the procedure and after the procedure, something like that. So before the procedure, obviously diagnosis is key. I'd write something like clinical diagnosis backed up by echo. Um, I will use echo to identify the uh, shortest route possible with the minimal complications. I'll say maybe I'll find the largest pocket of effusion. I'll choose the one which is the easiest to do with the least complications. And that varies depending on the patient. When I'm thinking about complications, I'm going to think about what happens if I put my needle in too far or I don't put my needle in far enough. And in brackets, I'd be putting for the not far enough is if there's a pleural effusion, that can be a bit of a pain in the arse. And I've certainly drained quite a lot of pleural effusions, particularly from a subcostal approach. I've drained a pleural effusion when I'm trying to drain a pericardial effusion
Mhm.
because the distance is always a bit longer to go through. So if you're a little bit off, you can hit pleura before you hit pericardium and you're starting to drain an effusion and you don't realize you don't realize until you're checking. Last thing I talk about is, looking at bloods, so coagulopathies, medications that patients are on. If they're on a truckload of those, I maybe don't go through the liver so often. But I've certainly had a man up vibe from various surgeons who do this a lot. They're like, don't worry about it, just crack on. Pre-procedure, I'll set myself up so that it's so The patient will often be, if they're not intubated, will be short of breath. So I try and sit them up as high as you physically can. So yeah, patient positioning, my positioning, so that everything's in line. I've got I'll be standing on the other side of the machine from the echo machine, and I will use the echo in a sterile manner to identify the approach that I'm going to go on. So if I'm going subcostal, I'll stand on the right of the patient, echo on the left, and everything's in a line. If I'm going apically, it's the other way around. It's on the patient's right, and I'm standing on the patient's left. And I'll have someone who knows a little bit about echo to hold the probe to guide me, because I'm going to use the echo probe to identify where to insert the needle. But then I hand it to someone and I just put the needle in. So it's not a ultrasound guided technique. It's just does that make sense? Well, it's guided, but I don't use it real time
Why is that?
because it's a bit hard with an echo probe because you can't really do it with a linear probe. I
Yeah.
find so I do it with an echo probe. So I just use and it's got a bit of the near field is a bit rubbish with an echo probe because it's used to
Mm.
going for something that's like 5 to 15 centimeters away. So I use the echo probe to show me where the echo free space is, best area, and I'll choose the one that's got the best chance of success and the least complications.
Okay.
Cool. Then I'll put the needle in. When I get flashback, I've got a three-way tap that I put on the needle. I've got a needle of syringe and some air in the other needle, and I draw back a little bit of the pericardial effusion, and then you do a bubble study. So you agitate the saline, and then you squirt it back into the pericardium, a few mils, and you have your friend who's either putting the image on the apical area or subcostal, depending on where you're going. You can go parasternal, apical, or subcostal.
Mhm.
And as you squirt in the bubbles, your friend can then try and find the bubbles in the pericardial space with the ultrasound probe. What you do not want to see is bubbles inside the ventricle. If you're going to be inside a ventricle and squirting in bubbles, you want to be inside the right ventricle, not the left ventricle. So that brings us on to the procedure. So as I said, the procedure is not done real time. You've got the ultrasound to guide you where you want to go. Then you poke the needle in the pericardial space. You check it with agitated saline. And where I'm putting the needle, I'm always aiming to kind of skirt around the heart and avoiding the LAD or the LV because you prang either of those and you can kill someone. It's easier than it sounds, to be honest.
Dark, really dark. Okay.
No, no, it's not that bad. But you've got to know what you're doing. If you're going to go for an apical approach, just make sure you got to, just get your handle of the subcostal approach first, and just
When you say the apical approach is the more kind of like advanced
yeah,
technique.
exactly. But you've
Okay.
got to, but once you know where you're going, and again, I'll show you, like if you're looking at the apical view, you just go an off-axis view. So what's actually down the middle of your screen is the right ventricle. So you skirt alongside the right ventricle.
Yeah.
If that makes sense.
And are you leaving any sort of like some sort of pigtail or some sort of catheter in there? So you're
And then
putting a wire in.
just the same, we taught Seldinger technique, put in a wire, then you put in your pigtail catheter, and then you check it again with the agitated saline, and then I take an X-ray, and we go from there. I drain out about 300 mils at a time and then turn it off
Yeah.
for another 20 minutes and open up again, unless clinically it needs to be more urgent, just because you can get that RV um, transient, decompression. As you decompress the pericardial tamponade, you can get RV decompression syndrome.
Is that basically just acute RV dysfunction?
Acute RV dysfunction, it just gets stunned. Fingers crossed. Cool. All right. Just in the meaning of time, we might move on unless you got any questions about that. All right, let's go to the last one. So, who turns it? Andrew. So, list 4 features that help differentiate constriction from restrictive cardiomyopathy.
Sure. So be looking for signs of restrictive filling. So I'll be looking at both Doppler and 2D imaging. The Doppler imaging I'll go over first. I'm looking for signs of restrictive LV feeling. So you might see a heightened E wave on your mitral inflow velocity. You would also sort of see a diminished A wave as well. You'd also be looking for signs of annulus reversus, where you get an increase in your medial E prime as compared to your lateral E prime. And then otherwise, you would also be looking for 2D changes, including biatrial dilatation is more likely to be associated with restriction. And then you would lose your mitral flow changes that you would see in tamponade. And then from a 2D point of view, you'd also be sort of thinking about the size of the effusion, whether there's anything inside the effusion, if there is an effusion.
Okay, so
And
you had number one, you had the E wave,
maybe I've misread this question. Yep. So E wave, a
two
high E wave.
annulus reversus,
Yep.
three was
Biatrial dilatation.
atrial dilation, and then four was
Um, that was I
was
said inflow variation
inflow
reduction. I'm getting
variation.
confused with tamponade. I don't think that's a good answer.
No, you're not too bad, not too bad. So if it says list four, again, all you have to write down is one, two, three, four, and then put
Yep.
features in. And again, it's about how to differentiate constriction from restriction. So
Yep.
when you talk about the E wave, for the acute severe diastolic dysfunction, they've both got nasty diastolic dysfunction. So that's going to be
Yep.
the same between both of them because it's not going to be able to differentiate it. So
Yep.
you're not wrong, but it just doesn't answer the question, unfortunately. The things like the annulus reversus absolutely does because that's pathognomonic for constriction. The biatrial dilation, again, you can get that in both of them, and it's not going to be able to tell you. You're absolutely right. In my experience, normally it's worse in the restrictive disease, but I'll show you a case in a minute where constriction absolutely has got huge atrial dilatation. So again, unfortunately, I'm not sure that would help you differentiate constriction from restriction. The inflow variation, can you give me a little bit more because you can get the respiratory variation, but it's much more common in constriction. So I think I'd probably give you that one. So I think you've got 2 out of 4 maybe there. How about Sarah? Can you give us any more? So we've got the annulus reversus, we've
Yeah,
got the respiratory
I also had
variation.
annulus reversus. I had marked variation in inspiratory E wave
Yep,
velocity with constriction, not
yep,
present with restriction.
yeah,
I
good.
had
Did you say, sorry, when I said the E wave, did you say the E wave and respiratory variation or just the E wave was high? Did I misunderstand there, Andrew?
E.
No, Andrew, when you said it the first time.
No, I said it was high.
Yeah. Okay. So the respiratory variation is the key there.
Variation.
Just make
Yep.
sure I
Yep.
understood. Yeah, very nice. So yes, huge respiratory variation. Very nice.
I had concentric hypertrophy, often might be normal in constrictive, but more
Would
common
it
present.
differentiate?
Beg your pardon?
Would it differentiate?
I mean, I think if someone had like severe concentric hypertrophy, that would be more in keeping as a 2D feature, but I feel like your face is saying it wouldn't.
Yeah, I just don't have it in the magic answers. So I
Okay.
think you
And then
get,
I have to say I also had severe biatrial dilation.
yeah, right.
So I'm probably
But again, that's, I guess, the severe bilateral dilatation to show constriction rather than restrictive disease. 'Cause I think it's
so
more
to show
likely
risk.
restrictive. Yeah, yeah.
No, I said biatrial dilatation more common in restrictive cardiomyopathy and concentric hypertrophy, especially more than 1.2 centimeters,
Yeah, fair enough.
more common in restriction.
Okay. Um, the ones
What's in
that
the magic
I've got
answer?
written down for me are particularly, again, thinking about constriction, it's because of the pericardial thickening. So
Yeah.
pericardial thickening and calcification. Yep. Then you've got the pathognomonic ones are the annulus reversus, so medial E prime moving more than the lateral, which is the only disease where that happens.
Mm.
The big one is that septal bounce, the one that they always show in the ASE exams, is if you've
Yeah.
got anything with a respiratory phasic monitor, an M mode or a hepatic vein, it's always constriction. And no, I'm kidding. But they love putting that in there because you've got this respiratory phasic changes, and so you're getting a septal bounce with respiration, is a really
That's
good time.
mid-diastolic, right?
Yeah, very nice. So it's during the respiratory cycle. So you're getting respiratory sort of septal shift, that ventricular interdependence. And
Yeah.
then the big one they talk about is diastolic reversal diastolic reversal in hepatic veins during expiration. With restrictive disease, it's inspiration. Yep. So I always remember that by RICE. So RICE. So restrictive has diastolic reversal during inspiration. Constrictive's got it during expiration. So yeah, it's
Nice.
all about those. It's the respiratory changes because you've got a thickened pericardium, so it's a bit like tamponade. So nothing. So all the changes that happen in your hemodynamics from breathing are transmitted with much more exaggeration to your ventricles because there's no pericardial give. It's pericardial restraint.
Mhm.
Cool, nice. How about the last one? So explain how do you diagnose effusive constrictive pericarditis on an ICU echo and how this would alter management compared to a simple tamponade. Back to
Is that
you. That's Sarah,
okay?
that's for you.
Yeah. So I would say constrictive pericarditis is diagnosed based on 2D and Doppler imaging parameters, principally increased thickness of the pericardium on 2D, presence of a septal bounce or shudder with the interventricular septum abruptly um, moving to the right or moving across to encroach upon the LV in mid-diastole, with evidence of a plethoric IVC and evidence of on Doppler, high early E-wave velocities and short deceleration time, inspiratory decreases in mitral valve inflow during inspiration, with increases in tricuspid valve flow. Sorry,
Beautiful.
decreases in during inspiration of mitral valve flow and increases in tricuspid valve flow, um, based on your E-wave parameters. And then on color Doppler, you might see normal or increased color velocity and early diastolic filling across the tricuspid valve. Um, I think that the presence of effusive constrictive pericarditis, depending on the signs and symptoms, it may or may not be a clinical emergency versus like an acute tamponade that has occurred sort of as a result of some sort of physiological insult that's possibly more acute than if, you've got a constrictive pathology.
Maybe just from a pathological point of view, what's the main difference between a simple tamponade and an effusive constrictive? Just to get you
What's the
thinking a bit.
difference?
Yeah.
Um,
What makes it
well,
effusive and then constrictive?
so with constrictive pericarditis, um, the limitation in chamber, I guess, expansion leading to those pressure pressure equalizations, is, a rigid pericardium
Yeah, nice.
versus in tamponade, where more commonly it would be fluid that exists in the
Yeah,
pericardial space. So the pericardium itself is still elastic. It's just that
yeah,
the
really nice.
space is now
And it
being.
often comes from infection, right? So,
Yeah.
strep, staph, other, parapneumonic effusions that can affect the pericardium. Otherwise, I've seen it. And so it's often come with, features of sepsis. I was going to say it. I know this was how would you diagnose it on an ICU echo? So everything you said was right. But with the inflammation that you get in the pericardium when you drain the effusion, what do you think happens to the pressures, like things like a CVP? What's going to happen to your right atrial pressure?
Once you drain
Yeah.
in constriction,
In effusive constricted.
I would have thought that the pressures within the heart chambers don't improve as impressively as if it
Very
was
nice.
just simple
Very
night.
nice. So I think that's one of the big ones for me is that some of these echo features that you've got that you're talking about diagnosing tamponade, they disappear when you drain the tamponade, a simple tamponade, but they don't disappear when you drain the effusive constrictive pericarditis. Also, the
Because for
ones,
me, when you read the literature and compare constriction versus simple tamponade, like a lot of the tables seem to basically say everything is the same except for like the mid diastolic septal bounce and like the shuddering, like the early diastolic filling and then abrupt cessation. But like that's it. I reckon that's pretty subtle. You know what I mean? Like,
Absolutely, it is. It is, and that's why I think the diagnosis often comes from from the pericardial fluid, which is going to have stuff in it. So,
right.
when you send, this is why we're sending them off for MCS, right? Looking, when you do a simple tamponade, it's, more often than not, there's no signs of any cells in there. Sorry, as in bacterial cells in there. You can have signs of cancer, of course.
Mm,
So you get malignant cells, but actually having signs of infection that's within the pericardial space is what makes it effusive and then constrictive most of the time. So it's infection that causes that, inflammation that causes the constriction, and that's why it's
mhm.
so bloody tricky to treat. Um,
So to kind of summarize that, are you saying that it would alter management because more commonly it'll, from a medical management perspective, you may be concurrently treating sepsis with all your antibiotics, fluid resuscitation adjuncts that you would with someone who has sepsis. Um,
and they're more
and
likely to need surgery.
and I was going to say, and the definitive management is a pericardiectomy. Is that
I think
correct? Or window?
pericardial windows at the beginning. I've heard stories of people actually, bathing it when they've gone in there and basically putting antibiotic fluid to wash out the space. So you've actually sort of getting source control, if you like, by clearing out the pericardium. And people have needed pericardectomies down the track. I don't think they do these urgently when
Yeah.
everything's
Okay.
inflamed, but it's it's source control.
Pericardial window as opposed to
Yeah,
definitive management with
yeah,
drainage, like with a
exactly.
picked up. Yeah. Okay. Great.
Anti-inflammatory drugs, antibiotics, and potentially pericardectomies.
Hmm.
Nice. Do you want to see a couple of should we do a couple of cases? See how far we got. We only got 15 minutes, but we'll see how we go. All right, Andrew. So have I shown you have we gone through any vivas before?
Not really.
This, forgive me if the first one's probably more of just a show and tell one, which I've stolen. But what's normally going to happen is there'll be because you've got like 7 or 8 cases that we got to get through in 40 minutes. We'll normally give you maybe 5 or 6 images to go through. Again, you'll be in charge of it, not here, unfortunately, but you'll be in charge of moving the slides forward and backwards, and it's approximately a minute a slide. And the examiner may just tell you to speed up because everyone's got to do the same number of cases. So there is a sort of time element to it. So when you're trying to talk about your findings, there's normally a little stem. Then you're going to give your findings and just get straight to the money. You don't have to say, oh, this is a parasternal long axis view. The left ventricle is normal in size and function. The right ventricle looks normal in size and function. The aortic valve, just get to the money and imagine you're talking to another expert. Okay. It's going to be a little different with this one, as I said. This is just a case of a tricky tamponade. So 71-year-old male, 20 days post pulmonary ablation for AF. He's anticoagulated with dabigatran, then apixaban. He's had sudden collapse at home with chest pain and ED. He is hypoxic and he's had a collapse. I think what we can see here is that he's got a blood pressure which is 100 on 60, and he's tachycardic and he's tachypneic with low saturations. He's got a lactate of 5, sorry. He's got a lactate of 5, and he's acidotic with a rising CO2. Okay. What do you think of these pictures?
I don't have any pictures.
Yeah, I don't have any pictures
Let me
either.
see you, Sam.
Oh, sorry.
Looks great.
Let me try that all again. Try that.
Oh, okay.
Better?
Yeah,
Have you echo
it's better.
pictures now?
Pardon me? Yeah, we've got
Yeah.
echo pictures. Yep.
Cool. Sorry
Yep.
about
Okay. So parasternal lung axis, I can see a pericardial effusion that appears at least moderate to large, mild to moderate, or moderate in nature, maybe centimeter and a half.
that. Yep.
Uh, the aortic valve, look, the pictures aren't great.
Yep.
There appears to be something adjacent to the right ventricle, which may or may not be a clot. I'm not sure.
Can you try and
In
describe it before you tell me what you think it is? I think you're right. It is a clot, but how are you making that this distinction?
because it looks like one. So there
You're
is
allowed to.
there is a echogenic like linear thickish mass that appears adjacent to the pericardial
Yeah,
wall. Sorry, to the myocardial wall,
beautiful.
um, which echo with an echo density similar to sort of like a thrombus.
Beautiful. So another way you might be able to say is that it is a linear, smooth, homogeneous, echogenic mass, linear mass that has some independent motion as if it's floating in liquid.
Yeah.
So just keep that idea of, heterogeneous versus homogeneous. And again, that's for different densities of clot. I'd go on to say it looks like an acute thrombus.
Yeah.
And then if you can think ahead, what is my next question going to be?
So the next question is there evidence of tamponade?
Okay, yep. And give me what is again, what causes this? Because I think that would be the other question I'm going to say is that I think if you're seeing this guy in ED,
Yeah.
he's short of breath. And do you remember the story? Do you remember
He's
the
had a ablation at some stage.
ablation, but then sudden that was 20 days ago, and then he's
Yeah.
on anticoagulation, and then 20 days after his ablation, he's not feeling unwell for a couple of days, and then sudden collapse at home with chest pain. And then you see that. So
I guess
what's
the
going through
question.
your head? And that's what I think the good
Yeah.
candidates,
Yeah.
if I've got to ask you the question, it makes me nervous because I want your reaction to be the same as my reaction when I took this picture, which is what?
A reaction of concern. And my question is
Yes.
what's the cause of the um, of the sudden collapse and whether there's any sort of dissection or
Nice, my man. Yeah. Have you got an aortic dissection?
yeah.
Beautiful. Because acute onset hemopericardium comes from a couple of things. One is a dissection that goes through the root. What's another one?
Um, just to answer the question again, you cut out a little bit, sorry.
Oh, sorry. There are
That's
only
part
sort
of
of two
that's part.
diagnoses that come into my head from, or maybe a third, but for acute bleeding into the pericardial space. And one is an aortic dissection, aortic root dissection, type A.
Yep.
Yep.
And then I guess ventricular herniation in the context of an MI or something like that, which
Yeah,
seems to
nice. You're probably going to be dead with that, though, aren't they? I was also
yeah.
going to go just trauma, just chest trauma.
Yep.
And so the first thing again after I got that picture is I just can I again as I say you haven't been in an accident, I'm going to have a look at the chest. You when you fell over, it wasn't something else that caused you to fall over, and there's chest trauma, and you got I don't know a knife sticking in your back. So yeah, direct chest trauma. It can be blunt or sharp, and then some kind of rupture of the myocardium. And three, and then the aortic dissection. Beautiful.
So
So just on the short axis, probably best one you can again see that homogeneous, linear, smooth-walled, thrombus-like echogenic structure in the pericardium. It's at least moderate in size, and you've
yeah.
got an underfilled LV is the next thing to pick up.
And
Shitty
the
pictures. I
RV.
apologize. What is this feature?
Pulsus paradoxus.
Nice.
Yeah.
Pulsus paradoxus, and you can looking and seeing on the ECG as well. There's maybe a bit of electrical alternans in there as well. But again, just nice physiology showing big changes that correspond to the changes in his E-wave velocity. Nice. And why is this important, Andrew?
And so the IVC once again looks dilated and plethoric.
And why is it
Um,
important for the diagnosis?
so it's not a low volume state.
Yeah, good job.
It's a restrictive. It's a tamponade state.
Because we had that, because you've got that hypovolemic small LV.
Elevated. Yep.
So it's hypovolemic because there's
You've
no
got a
blood getting into the heart, but it's not because he's got low blood volume state. Yeah, nice.
oh, that's a fucking big plot, isn't it?
Yes. So what pathology have we gone through that? What would you do next?
So I'd look for it. I would call chondrothoracics as my first point of call, but then I would look for evidence of a dissection flap on a high parasternal long axis view.
Yeah, really nice. So this is what I got on the high, on the suprasternal view. I couldn't see any obvious dissection flap. And then this guy started to become more hypotensive. So he started to get more unwell and he was breathless. So I had a chat, just like you said, I had a chat with our cardiothoracics team. I arranged for an urgent CTA to exclude a dissection, which it did, but it also showed this large, bleeding source that I was worried, on those pictures I just showed you, that was taken probably about 15, 20 minutes afterwards, and I was worried it was getting bigger. So I thought there was ongoing signs of bleeding, and the hemodynamics started to change a little bit. So I made a decision to go ahead with pericardiocentesis, which was contentious. But you can see on these pictures here that the bleeding looks a bit worse, right?
Mm.
Don't know if I
The
can
infusion
display that.
definitely was, yeah.
So hence the decision to go ahead. So what approach would you use to drainage of this, and why?
Yeah, so sort of looking at the principles of the shortest possible distance to the biggest possible area of drainage. I think there's a few extra things to think about in this patient. It's also the nature of the thrombus as well. You're worried that you might get into trouble by getting stuck on the thrombus if you put a needle in there and not get any flashback. I think apical is actually a reasonable approach in this patient.
Yeah, really
Uh,
nice. And if you,
Looking
that's
at
exactly
the
what,
size of the effusion there and also the presence of non-clotted blood.
yeah, and the fact that he was on dabigatran and then apixaban,
Yeah,
um, and there was no major trauma that happened to him, and then suddenly he started bleeding. I mean, obviously, we tried to reverse the what we could, but it's a bit tricky, isn't it? Yeah, and again, sticking and someone who's maybe got risk of bleeding, sticking needles through it up to, it's up to 8 centimeters before you actually hit, or maybe even further before you hit the RV. Yeah, I did the same thing. And all I did there is I just go off axis. So I just tilted the probe around, so you're pointing more towards the RV, and I try and put the needle down adjacent to the right ventricle. Um, and yeah, so it went better. So straight after procedures, hemodynamics improved. We got out some blood, not a lot, to be honest. I think the clot didn't come out quite like I was hoping, but we got out about 50 mils, and the physiology markedly improved, and his lactate got better. Um, X-ray shows where the drain is, just down at the bottom down here.
yeah,
Um, and you can see the direction. I don't know how well it comes out, but the direction is sort of skirting along that right ventricle border. So very low. It looks like I'm sort of sticking into the spleen or something. I promise I'm not. But you can see how low I'm going, which is obviously the apical view right next door to the right ventricle. Drainage next day, the right ventricle is working, which is nice. The effusion has got much better, and he had a pericardial window done. Cool. So I think so the best clinical features to guide you to perform drainage for me is the shortness of breath and the shock. If someone's in shock with shortness of breath and the effusion, I probably drain it more often than I don't. I think this case was tricky for the surgical versus the transcutaneous approach. I probably shouldn't, and I don't think we should do it unless you're sure there's not a dissection or it's absolutely life-threatening
yeah.
and someone's about to die in front of your eyes. And I think if I could have given, if it was a bit more hemodynamically stable, I'd have just waiting for cardiothoracics to do a pericardial window because you get to take the thrombus out. And then
Do you have any
subcopulae,
concern when there's bleeding within the pericardial space that if you put a needle in there, you've now just created an externalized
100%.
conduit for blood? So, like,
Yeah,
say it's not
100%.
freely flowing, then you stop it so that you don't have,
Yeah.
so that you're able to, I guess, want of a better word, tamponade the bleeding.
Yeah, the problem is he was tamponading anyway, and his blood pressure
Exactly
was
right.
falling.
Like,
So, lactate's going up, blood pressure falling, no dissection flap. I guess my hope was giving him sort of the reversal that you can give for apixaban with prothrombin and trying to correct coagulopathies, bit of VIC-K or whatever. So just trying to give him that whilst draining him and just hoping that it would try and stop it. That was
yeah,
the idea. It was just I wouldn't have done it unless I thought there was, the
yeah, yeah,
waiting for the surgeon to get in and get everything done would take what, 45 minutes to an hour. It
yeah,
felt like he was getting worse in front of our eyes.
100%. Cool.
And then I think we discussed the approach. Um, might just talk through the last case. We've only got a couple of minutes left. So this guy's an unusual case of shortness of breath. He's a 52 Pacific Islander with acute on chronic shortness of breath. He's got a
Mm.
history of rheumatic pericarditis in the past before and
Mm.
TB. And what you can
Mm.
see on this chest X-ray to spoil the plot is obviously that he's got these pericardial effusions, which what drew everyone in. But the around the heart here, you can see there's a bit of a highlighting showing there's some calcification. Okay.
Mm.
Oh, hey, Raj.
Hi, Sam. I just got your link. I was
I'm
wondering. I
so
totally missed it. I'm sorry.
no, you're totally fine. And this session is recorded, so please jump back and have a look at it. I'm so
Sure.
sorry. I've only got a couple of minutes before I got to go and jump in a car and go to
Fine.
the
That's fine. I
airport.
listened. I
But
listen. I listen.
I'll try and be better with my organization, and I'll send out questions earlier,
Sure.
and I'll send out links more than
Sure.
2 minutes before, and
Yeah.
we'll see how we go.
It's fine. So I'm sorry. I missed
Thanks.
it totally. Sorry. I attended the questions. I wrote the questions. Yeah. I'll
Oh,
go
cool.
through.
Well, as I say, go through this. I'll try and stick it up online in the next
Sure.
couple of days, and hopefully we go through it, and we'll
Sure.
obviously do a lot more.
Yeah.
This is
Yeah.
just the last case of someone with constriction
Yeah.
that came through. So,
Yeah.
acute on chronic shortness of breath, and if you're seeing any echo where you're seeing respiratory septal bounce, and it's often tricky because sonographers sometimes can miss it. But if you're seeing normally on these echo images, we're giving you like 2 or 3 cardiac cycles, 1 to 3 cardiac cycles that are looped. If you see someone who's giving you suddenly 10, it's either going to be a bubble study or it's going to be someone who's trying to show you something that's related to respiratory phasic changes, not, cardiac phasic changes. And so here you can sort of see that there's a respiratory phasic changes going on here, but you've got to train your eye. And if you're starting to see that with someone who's got this, chronic shortness of breath issue, you've got to start thinking constriction. Okay. So what the question might be is what further imaging would you like? And what would your answer to that be, Sarah?
What further imaging would I like for this patient?
Yeah.
I would like and I'm assuming that you've completed the echo. Like it's not like,
Oh, sure, absolutely. You could say a
yeah,
complete
yeah, for
echo,
sure.
but if I said
Yeah.
you're only allowed sort of 2 more images, what would they be?
As in two different modalities.
Oh no, just 2 images. So if there were two, I've shown you 2 pictures here. I've shown you
Yeah.
a chest X-ray where he's short of breath with some calcium around his heart,
Yes.
calcium around maybe the pericardium. Now I've shown
Yes.
you these 2 pictures where we've got someone who's got this respiratory phasic changes, so the septal bounce that happens during respiration.
Yep.
What's the pathognomonic feature for constriction? Might be another way of asking the question.
I'd like to see a picture of the IVC
No,
during.
again, it's not pathognomonic. As I said, there's an echo feature where if you see it, you can say that's that, and that's going to be
Oh,
causing
like
constriction.
the interventricular septal shuddering, like the.
Almost, because again, maybe pericardial effusion can do a similar kind of thing. Think
Um,
annulus reversus.
oh, I know the rest of short, the
So
two
if
guys.
you had 2 pictures, I want the E prime. Oh, sorry, I'm going to quickly mute you, Raj. Sorry. Um, Annulus reversus. So I want to look at the
Yeah.
E prime on the septal annulus and E prime on the lateral annulus.
Sorry, I thought you were asking me did I
Um,
like a cardiac MRI, and I was like, not really.
and that would have been fair enough as well. So here is maybe a better example of those respiratory phasic changes. You can see that interventricular septal shudder. And here you can see why, because we're getting these marked respiratory phasic changes during expiration on the left side, and then during and even worse on the other side.
So Sam, when you've seen those images without a respirometer, or however you
Yeah,
say that word,
yeah.
basically looking for changes in the septal bounce. Is that kind of what you're
It's
checking
exactly
on?
right. So the septal bounce
It's
will
bigger and
be,
smaller.
yeah, exactly right. So it's going to be, you're going to see that sort of respiratory related septal bounce. And, that's the big signs of constriction, obviously. So here, maybe this would be a better one. You can see this much better now.
Mm.
So particularly if there's a
Number
respiratory,
three is not big, right?
yeah, nice.
If they're in AF, does that make it much harder?
Yeah, good call. But you're still going to get the respiratory phasic changes, and you can still use annulus reversus, but the
Yeah.
E wave velocity changes are a bit harder. And then this is the big one. So here's the septal where we've got a septal E prime of, say, it's about 14, and over here it's about 10 for lateral. So septal is much bigger than lateral. And with the septal bounce, the respiratory phasic changes, that is constriction. Tried to get the hepatic vein flows. You're looking for diastolic reversal in the hepatic veins during expiration. And unfortunately, I couldn't get it because he had a bit of an arrhythmia in there. But, we're looking for diastolic reversal there during expiration. So maybe we're seeing it here, but it's with a bit of the funny rhythm. It's a bit odd. And here you can see when they were doing the cath, I'm sorry I don't have it, but he had a prominent X and Y descent they call the square root sign. But the easier bit that I can see is you can see all this calcium and the sort of the constriction for the pericardium in there. You can see all that calcium deposit sitting around there. Okay. So I think that's probably it, guys. I hope that was useful. We'll try and do, one of these a week. I'll try and follow the syllabus. So next week we'll be going through left ventricle assessment. We might have a couple of those, to be honest. And we'll go from there. Okay.
Thank you. That was really helpful.
Great to see you guys. See you next week. See you.
Bye.
Bye.